So it's still morning. Good morning, everyone. And I want to thank the organizers for the invitation, and especially thank the survivors for those very powerful and moving testimonials this morning. I think it was absolutely essential for this particular conference, and I think it's something that no one will ever forget. So maybe this is the pointer and this is the changer. Yeah, there we go. I have no conflicts of interest to declare. I'm going to describe to you how the American Cancer Society has really made a significant change to the colorectal cancer screening guidelines. And primarily this change is to drop the age to begin screening at age 45. Now, I can tell you in a new era of guideline development, and I'm going to move through a lot of these slides rather quickly in the interest of time. In a new era of guideline development, it is extremely difficult to produce what we conventionally call evidence-based guidelines. They come under a lot of scrutiny. The last thing you want to do is to have somebody grade your guideline as not measuring up to standards of evidence in your recommendations. So you need to use extensive systematic reviews. You have to scrutinize very carefully conflicts of interest. And what you often find across guidelines is there's an enormous amount of duplicated effort at a very high expense in terms of time and resources. So one of the things that we've started doing is using other systematic reviews where possible. And in this instance, for updating our colorectal cancer guidelines, we used two very, I think, well done papers that supported the Preventive Services Task Force guidelines. One, their systematic review, and the other, their CISNET analysis. We also examined new trends in disease incidence and mortality. It's really very important every time you do a guideline to go back to basics. Has the disease burden changed? What is the evidence on the effectiveness and the efficacy of the tests? Are they well tolerated? Are they accepted? How solid is our evidence? We looked at new literature since the publication of the task force's recommendation to make sure that we were not missing anything since they completed their review. And we looked very specifically at literature on risk associated with age, gender, and racial and ethnic subgroups. At this point, I also think it's very important to mention the very important work of Becky Siegel, who is on the same floor with me in a different quad. Her data, this more important data that was published in 2017 in the Journal of the National Cancer Institute, really did cause us to bring our guideline development process to a sort of screeching intermission while we assessed whether or not we needed to be considering these new data and the recommendations. I also want to emphasize that these are not data that the task force had when they issued their recommendation. So the whole issue of, well, why are you recommending different things? Guideline development groups commonly have different recommendations, not because they reach different conclusions about the data, but they did their guideline updates at different times when different guidelines, different information was available. We commissioned the same CISNET groups to update the modeling analysis they did for the task group in a way that also included evidence on the rising incidence in younger adults. If you're doing modeling, you essentially want to reduce the influence of screening on incidence rates and on risk, because it can vary across different groups. So commonly, you're going to look at these data at a point in time when screening was not taking place. That's a very sensible thing to do. However, if there are differential trends in incidence and risk over time or in different groups, you miss that effect and might not make an important change in the guideline to address the needs of one or all groups. Now, this is the basic difference in the guidelines. I mean, as you can see, anytime you see a green check mark, it means they're essentially the same. Where you see a red check mark is that we recommend beginning at age 45. The task force recommended beginning at age 50. So what is the account for how we reach this difference? We had new evidence on the burden of disease by age and race. We looked at high-quality studies of test performance and the effectiveness of screening, and we looked at modeling studies where we do not have empirical evidence to answer every single question that you might bring to bear. You look at the balance of desirable and undesirable effects. For all of these, we found that the benefits significantly exceed the harms. And you look at the issues of value of preferences. One of the things we see in this country, of course, is that the tendency to only recommend colonoscopy means that we do not screen as many people as we would like, because some patients simply have no intention of getting a colonoscopy. So we strongly assert that patients should always have an option of either a structural examination, colonoscopy, CT colonography, maybe even flexible sigmoidoscopy, but I'm not wild about that, or a stool test, and then they have a range of options to choose from there. Now, you've seen some of these data. These are a little older than what you saw this morning, but I'm going to go through them quickly. A rather remarkable thing that we've been observing is this increasing incidence in young adults. We've seen a declining incidence in the older adults, but under the age of 50, we've seen these increasing incidence, and nobody's really understood why that's been happening. But we know more about it as time goes by, and this was the real important contribution that Becky Siegel and her colleagues made in 2017. We already have, not the American Cancer Society, but previously some of the GI groups recommending that Black adults start screening before the age of 50, largely as a result of this higher incidence that has been observed over time associated with a higher death rate. But what we observed in the more recent period is that whites had caught up with Blacks in terms of this incidence before the age of 50. So if we were going to make a recommendation specifically for Blacks, we were going to miss an opportunity to explain, well, why wouldn't we make that same recommendation for whites? When we looked at the trend data that was published by Becky Siegel and her colleagues, you see this very strong birth cohort effect, specifically for those birth cohorts born after age 45. And if you can eyeball this trend, you see it gets steeper the younger the birth cohort is, which suggests that this incidence is rising more steeply in the younger groups compared with the older groups. It really is the kind of a graph you want to, I want to, all of us should, linger over for a time because it's telling us something very interesting. And one of the things it's telling us is that this increase is steadily increasing. So Becky described it once to me as kind of like the way a tsunami behaves. You know, you have smaller waves in the beginning and bigger waves following that. And as we're seeing in the more recent data that she showed earlier this morning, that trend is increasing just as she and her colleagues predicted that it would. We see that a substantial fraction of this increased incidence is confined to the 45 to 49 age group. And we see that the proportion of colorectal cancer in adults under the age of 50 has doubled since 1990. More noteworthy is that the increase in the annual percentage change is higher in the 40 to 49 group than it is in the 50 to 54 group, which again suggests that this increase will continue to carry forward in time and that the burden in younger adults is increasing. A figure we use more and more is life years lost, life years gained. And what we observed is in the 40 to 45 to 49 year group, 10% of all life years lost each year to a death from colorectal cancer attributable to a diagnosis in that period is in the 45 to 49 year age group. And I think most compelling, if you wanted to look at one single statistic altogether, is that in 2018, in 2015, the incidence rate of colorectal cancer at the age of 5 is about where it was in the early 1990s at the age of 50. Now, you do see a steeper rise in the 50-year-olds over time compared to the 45-year-olds. But again, that's because we've been recommending screening in this age group for a long time. So you are getting a lead time effect. But if you look at where age 45 was when we did the guidelines and where 50 was back in the 1990s, when actually I think the American Cancer Society was the first organization to set the recommendations at 50 right in 1992, then they're about the same. The modeling results showed the rather remarkable improvement in life years gained as a result of factoring in the increased risk, simply meaning that you had more disease and that the opportunity to apply the standard recommendations that the task force recommended, that the American Cancer Society recommended, showed that these models were highly efficient. In fact, in almost all scenarios beginning at age 45 was more efficient than age 50. And one thing I should mention right now is that in some scenarios beginning at age 40 also looked productive. And this just gives you an indication of what is going to be gained by starting at the age of 45. which is a measurable improvement in life years gained under every single scenario of screening with colonoscopy, CTC, FLEX-SIG, FIT, or any of the 3 stool tests. So overall, and we're always happy to see this, the media results, media interpretation of the recommendation was very favorable and positive. You know, we are holding our breath when these things come out. Some of you remember when we came out with our new breast cancer screening guidelines. We're not going to go there. But the GI literature has been less favorable, and of all these 5 reports, our favorite is the the recent colorectal guidelines, from guidelines to headlines, beware. Rather alarming title. And we're working on a response to each of these. We felt that we should let them all come out and for the environment to cool down a little bit before we did respond. So how do we answer these things? And I'm going to do my very best to keep sarcasm to a minimum. So the criticism said, well, colorectal cancer is a different disease in adults under 50. The emphasis was always in adults under 50. We're not recommending screening in all adults under 50. We're recommending it among adults 45 to 49. And we looked and found no evidence to indicate that colorectal cancer is in any way a different disease in the 5 years between 45 and 49 and in that period of time under the age of 50. Well, the burden of disease is very small in this age group and high costs and many harms for a small benefit. Well, the burden of disease is not very small in this age group. 45 is the new 50, for one thing. So anytime you're going to begin screening in a cohort of people, the burden of disease is going to be smaller when you begin. It's going to be greater towards the end. There's going to be different metrics about cost effectiveness. Certainly you prevent many, many more life years by detecting a case in a young adult. You save very few life years for detecting a case in an older adult very oftentimes. So the diagnosis between ages 45 to 49 accounts for 1 in 10 life years lost. That's not insignificant. There's no empirical evidence. Recommendations are based on modeling. This is one of my favorite. Modeling is great when it says what you want it to say. And when it doesn't say what you want it to say, then you can say, well, this is just modeling. So we fall back on the general adage, all models are wrong, some are useful. But the simple fact of the matter is that we cannot do a new prospective randomized controlled trial every time we have a new question. Models are dependent upon the parameters that are entered into them. And the CISNET colorectal models are very, very good. And in fact, our colleagues who were doing the models were really quick to embrace our recommendation that they change the underlying distribution of risk in the models that they had been using for years to reflect the current distribution of risk in both blacks and whites, males and females. And these are the very same models that the task force used, and when the task force upgraded their last guideline, these models also recommended starting at the age of 45. But the task force did not feel completely confident that there was sufficient evidence to make the change at that time, and they were using the old risk-based models. It was a consideration at the time, and they faithfully reported it was a consideration at the time, but they had chosen not to do it. It's important that we concentrate further on adults 50 and above. Well, no one can argue with that, but it's a relatively empty criticism. Of course we want to concentrate more on adults 50 and older, but that is not a reason to not concentrate on an equivalent risk group between the ages of 45 and 49. The new guideline will worsen existing disparities. This is a real possibility, but these disparities have been with us for a long time, and we should have been doing more about them to date. And this is just another reason to look very closely and measure access issues in every corner of this country to ensure where there is limited access that we have strategies to overcome that. The new guideline will strain existing capacities. In some areas, this is a real possibility. There's a greater emphasis on high sensitivity stool testing, which will exert less pressure on colonoscopy capacity. This is really true. There is no reason everybody has to have a colonoscopy, and once you have a stool test, it doesn't mean you're committed to having stool tests for the rest of your life. But it's better to do a high-sensitivity stool test than to wait years to have access to a colonoscopy. And this is an interesting thing. You saw this data that was just shown, that Dennis just showed, that most adults do not begin screening at age 50. We wish they did. Whitney Jones has made a very big deal of this for as long as I can recall. And as you saw from those graphs, really most adults start screening after the age of 55. That's a long time to ease into this. So the fact of the matter is that if you look at 45 to 75, you can do the math, that's a 40-year period. It's been presumed that that's going to represent 4 colonoscopies, 1 extra colonoscopy for every adult in that screening age. Fact of the matter is most people will not start screening at age 45. So if you do the math again, it probably is only 3 lifetime colonoscopies under either scenario. The way I think about this is that you can either begin your surveillance and screening early and identify those adults who are at higher risk of disease at an earlier age, and in later life, if an adult has a history of no polyps and normal examinations, you may not even need that last colonoscopy. We have to get an earlier start. And one of the things that we believe that these guidelines may do is focus new attention on earlier onset colorectal cancer and not only prompt primary care providers to bring this issue up before the age of 50, but be more attentive to symptoms of disease in adults under 50 as well. Finally, the argument was advanced without any data on capacity, but we did point out in this article that the Centers for Disease Control had done a survey on endoscopy capacity and showed there was considerable capacity left that could be met. And this doesn't factor in at all the overscreening that takes place in many adults today who are in short follow-up colonoscopy for minimal risk hyperplastic polyps. So modeling convincingly demonstrated that due to rising risk in incidence of colorectal cancer, that beginning screening at the age of 45 was efficient and would be effective according to all conventional measures of effectiveness. The trend of increasing colorectal cancer incidence suggests successively younger birth cohorts suggests that the recommended starting age at age 45 will continue to be appropriate, and in time we may even be dropping that age to age 40. This has come up in discussion. Benefit-burden balance strongly favors changing the starting age for 50 to 45, and I would leave you with this last very simple and straightforward conclusion. If you embraced the recommendation to screen Black Americans before the age of 50 based on previous guidelines among the GI organizations, and if you always felt that beginning screening at the age of 50 was appropriate, then you should embrace beginning screening at the age of 45 today. Thank you.